and thank you very much for the very kind introduction. With that, I'd like to get started. I have a disclosure to say that neither I nor any members of my family have any actual or potential financial interest to disclose relating to the content of this presentation. My involvement with processed EEG began in 1997 because for 5 years the surgeons loved how the patients woke up from the propofol, but they kept crying about, can't you do it cheaper, Dr. Friedberg? So when I was rolling out my Society for Office Anesthesiologists at the 1997 International Anesthesia Society meeting, Aspect Medical was down the hall from me, and they said, you ought to go down and check this out. This guy's got a propofolometer. So, well, that sounds pretty good. And I struggled for a year trying to make the darn thing useful. And a year later, I added the real-time EMG of the facial frontalis muscle to make it work. And so I'm pretty excited about my 20-year experience I have to share with you today. And I do have a self-funded nonprofit as well. So what I hope you'll get out of this is to learn the value of the incremental propofol induction for airway maintenance and avoidance of the difficult airway, and to learn how to avoid ketamine side effects, and to be able to tell the difference between purposeful and non-purposeful movement under IV sedation. So sometimes I think in lectures we're too subtle, and I thought this slide I'd throw up there and say, these are 4 beliefs that just ain't so. Opioids are essential for every anesthetic, not so. Ketamine, you always have hallucinations, not so. We always give per kilogram dosing for every drug, not so when it comes to ketamine. And under IV sedation, when the surgeon has injected local anesthesia, vasoconstriction doesn't equal adequate analgesia. And the bonus 4th belief is that propofol, then ketamine, which is what I do, is not ketofol. You may have heard of the mixture of ketamine and propofol. Very common. I have nothing against it. It's just not what I do. So the question comes down to style. You see here on the right there, the left side, you see a Queen Anne Victorian, and on the left, a Bauhaus, on the right, a Bauhaus. Both structures provide shelter, okay? The style that I evolved was called minimally invasive anesthesia for minimally invasive surgery. I published this in 2004 in a trade journal, Outpatient Surgery Magazine, and a few years later, the prestigious anesthesia department of Sweden's Karolinska Institute put it on their website. So I asked one of my friends in the academic world, I said, why would they put this trade journal article on their website? And he said, well, apparently the Swedes understand that not everything that's useful is validated in a level 1 study. Okay. This is what I hope I will be known for in history. You've heard of Virchow's triad and Cushing's triad. This is Friedberg's triad. Hopefully all of you got some envelopes with some of my material in it. Basically, measure the brain, preempt the pain, emetic drugs, abstain is how we framed this study, this presentation. And why do you want to measure the brain? Of course, pretty obvious. We're medicating the brain. And as Lord Kelvin said, if you can't measure it, you can't improve it. Why do we want to preempt the pain? Ben Franklin said it best when he said an ounce of prevention is worth a pound of cure. And as far as emetic drugs, our friends, the opioids, legendary PONV authority Christian Apfel said, as long as emetogenic agents are part of the anesthetic regimen, the use of antiemetics is of limited utility. Limited utility is academic speak for doesn't work so hot. So let's roll along here. We're going to talk about measuring the brain. Originally, it was the 5 blind men trying to describe the essence of an elephant. And I've twisted it to say, how about the 5 blind anesthesiologists trying to figure out how much drug to give the patient? Okay. Typically, at the top, we use body weight, right? We'll give them, 2 milligrams per kilogram push of propofol, and they'll be asleep. In Europe and other places in the world, they have TCI, target-controlled infusion, where you dial up a blood concentration with the inference that a certain concentration will always give you the same brain response. Another belief that doesn't hold up so well. We can titrate to changes in heart rate and blood pressure. 2 other things, pharmacokinetics and pharmacodynamics, neither of which I understand, but are very complicated mathematical models. And then we could use body mass index. But again, as Lord Kelvin said, if you can't measure it, you can't improve it. Now, one of the things I want to remind you of this 1999 study, Karen Domino and colleagues found that at least 50% of patients who had awareness with recall under anesthesia had no changes in heart rate and blood pressure to let the anesthesiologist know that something was amiss. The sad part is although awareness under anesthesia may be associated, but not always, may be associated with PTSD outcomes, there are no deaths documented. That is not true when it comes to anesthesia over medication, which is the natural consequence of not directly measuring brain response. Lee et al. In 2009 published this study, which was not even deemed an article of great interest in the anesthesiology journal. And 1 death a day, independent of comorbidities, happens simply from anesthesia over medication. Now, I realize that 365 deaths a year is a pretty small number when you compare 50 million anesthetics being given. But if one of those people happens to be a parent or another loved one, that's a bad thing for a $20 sensor. So I want to look at the 2 ways you can give anesthesia. The way we typically play the bell curve and give the average patient, the average mythical 70 kilogram patient, a dose. Some people on the left are going to be too sensitive to that, and some people on the right are going to not respond very well. So you have a choice of medicating the 80%, or you can do a direct measurement and measure 100%. You have a choice of cortical monitors. I'm not here to sell any particular device. The 3 devices that are commonly spoken of is the bispectral index, the SedLine, and entropy. Obviously, anesthesia medicates the cortex. And if you're going to practice in a scientific fashion and a low-stress practice, I would say, measuring beats the heck out of guessing. And after my first 20 years, I'm a pretty good guesser. But measuring is kind of like shooting ducks in a barrel. It's like, an open book test. Literally an open book test. The number from the forehead guides your dosage. And so here are the numbers for the bispectral index. 98 to 100 is awake. I chose the middle section, 60 to 75. That's where I've been dialing my patients for 20 years and 4,000 plus cases. General anesthesia, 40 to 60, and over-medicated below 40. Now, these numbers aren't accurate unless the baseline muscle activity of the forehead is calm. And the problem I'm going to show you here on the next page, yes. The top is what I worked with for a whole year. Drove the salesman crazy. I had the first biz monitor in Orange County, California, because the salesman was just breaking in the route. So I know I had the first one. And I kept coming back to him saying, I just can't get this darn thing to work. No matter how many times they said, it's a processed EEG. It's delayed 15 to 30 seconds. I couldn't get it in my mind. What were they trying to tell me? Finally, at the end of the year, in frustration, the salesman looks at me and says, why don't you try trending EMG as a secondary trend? Now, I'm sure he had no idea what he was telling me. He just wanted to tell me something, get off my back, Dr. Friedberg, stop bugging me. So the difference between trying to use the biz number by itself is like trying to drive your car with information looking in the rearview mirror. It's a wonderful place, wonderful information telling you where you've been. We're in the operating room. We want to know where we're going. We want to know what's about to happen. And that EMG spike, I don't have my pointer here, but that's okay. The little red on the bottom, if you can see, when that spike goes up, that is the patient's way of saying, by the way, I'm about to wake up. Could I talk you into a little more propofol, please? And if you respond to that as quickly as you normally would respond to a heart rate or blood pressure change, giving incremental more doses to get that EMG back down, you see that the yellow stays within the desired range. How many times have I heard the story? Somebody said, well, the biz was going along at 45, and then all of a sudden it went up to 80. Well, of course, all of a sudden, because you weren't responding to that. Now, I think a lot of you have plug-in modules, so you don't have the ability to display the trend. But once you get the biz to the desired range of 60 to 75, where I am, or 40 to 60, the number you really want to pay attention to is that EMG. Doesn't help you if you have muscle relaxants. But in my practice of cosmetic surgery, even the Botox patients have enough electrical activity. You never see the brows move. It's an infinitesimal signal. Okay? So now I want to tell you a little bit about the airway. We always focus on the genioglossus muscle, the tongue. But in fact, when you titrate incrementally, as I'm about to show you, the other muscles actually come into play. The temporalis, the masseter, and the orbicularis, the kissing muscle. So basically, more than half my patients are not instrumented. Why? Cosmetic surgery patients will complain of a sore throat, and if you maintain their airway safely without sticking something in their mouth, it's one less complaint you have to deal with. So a third patients are in the right tudectomy position, chin up and head rotated laterally. If that is enough to keep the genioglossus muscle off the back of the throat, an unheated IV bag underneath the shoulders will add to the force of extension of the genioglossus. Very, very simple, non-invasive manipulation. So the principles are very simple. If it ain't broke, don't fix it. The reason we have the difficult airway is we insist on giving that 1 or 2 milligram per kilogram slug of propofol. Bam. Right? Most of these patients we're dealing with are elective patients. They come to the operating room breathing spontaneously through an open airway. What happened? We did a bolus injection. So I'm going to show you something that's been on the internet for some years. There's no shame in spontaneous ventilation, and you really never want to be in a situation where you can't ventilate and you can't intubate. So when you see my thumb touch you see there's only one pump, okay? Plastic surgeons would get hysterical if you brought 2 or 3 pumps in the operating room. It's just not going to happen. Every time I touch the pump, it's a 50 microgram per kilogram bolus over and over and over again. It's going to take me about 2 minutes and 20 seconds to get the patient to sleep. Okay? You'll notice there's no change in the SpO2 tone. Nobody's there holding the chin up or shoving instruments in the airway. Very, very simple. All right, let's see if this will roll. The EMG will start to decrease before the yellow, Of course, the EMG is going to go down before the biz because it's a real-time signal. Just like it's the EKG.
Yeah, especially when lying down, standing.
I'm not a new person, right? Thanks, I'm going right now. I feel it.
Hopefully it feels pleasant.
It feels pleasant. It's like my ideal way to die, but I mean...
Well, we tend not to do that.
And I'm like 106, you know?
Yeah.
I want my dog by my side,
How could you put somebody to sleep?
What can you have? A Roddy. Oh, I have a daughter too, but... So... Alright, here we go.
So this young lady is a nice young lady.
Will I be twitching?
No, no twitching.
I might be gassy because I didn't eat, but...
Yeah, that's okay. We don't charge extra for gassiness.
I'm feeling a little drunk.
It's pleasant though, isn't it?
It's a drunk feeling.
Yeah. So
I might say, I'm sorry staff, but I might say shit that I don't.
You would say.
Just don't worry, I haven't had food since 10, so.
Yes, fortunately this little video doesn't have audio in it. It's just the video. My bad. It was on the camera. I didn't know the pinhole was it.
This is a nice feeling.
Isn't that nice? Just about the same. Now you know why everybody likes Dr. Friedberg.
And when I get home, can I eat?
Yes. Immediately.
Okay, but it makes some good courage. If I wake up and very anesthesia, I can eat, right? How many chances for the... How many... Put your arm right here. I spend...
Pulse ox hasn't changed, has it? Pretty boring way to go to sleep. Then again, at my age, boredom is a wonderful thing. Make sure
I got both.
Saturation.
I got her and I got the biz in frame.
Super. Perfect. That's great. You can stop. So once you have the patient in the zone that you want and your base is 25 mics per kilo per minute, there's going to be 2 things that are going to happen that you have to make an adjustment for. Either the biz keeps going down, which means your base rate is still too high and you have to keep backing off until it comes back up, or it's going to go the other way, in which case you're going to have to increase the rate. I thought this was self-evident, but I thought, we'll just throw that in as a little bonus in case you think that nobody gets anything but 25 mics per kilo per minute. Okay. The second part of Friedberg's triad is preempt the pain. The shocking thing here is that once you sedate or anesthetize the patient's brain, it can't differentiate between the malevolent intent of a mugger's knife and the therapeutic intent of a surgeon's scalpel. It only knows one thing. OMG, we've been invaded. Boom. And the internal pain fibers go on high alert. Right? Now, if you take that out of the equation, everything you thought you knew about watching patients wake up changes dramatically. The first 50 cases, I did propofol and ketamine. Mostly, I'm concerned nobody, God forbid, should have hallucinations because my little experiment that I couldn't find any information about was okay. Hypnotic doses of propofol do block ketamine-induced hallucinations, but much more effectively if you incrementally induce it so you maintain a stable level. Whereas if you give a bolus, you're going to see a sharp increase in the concentration, and then as the propofol gets redistributed, the concentration is going to be dropping right about the time the ketamine is hitting. So you don't want to do that. Stable things here. All right. Another real concept for you is the brain can't process information it never receives. So if the brain doesn't know the body's been invaded, what's it supposed to do? It's not going to do anything. There's a great discussion among my fellow opioid-free colleagues in Europe and some here that says, no, the unconscious brain can't feel pain. Okay, then why is just a straight propofol drip not good enough? Because it isn't. Something's going on, whether you call it pain, nociception, noxious input, or just bad juju. I'm not sure. But all you have to do is get that stable level of propofol on board and get the ketamine on board 2 to 3 minutes ahead of whatever stimulation you have. In my practice, it's multiple injections of local anesthetics. In your practices, it's skin incisions or trocar punctures. Okay? And the reason 2 to 3 minutes are necessary is you have to have a couple of circ times for complete saturation of the NMDA receptors. Now, I worked when the first guy I developed this for was a jackrabbit. He wouldn't wait. And even then, okay, was all right. Okay. Another concept I have here, when I talk to you about those EMG spikes, those are incipient arousal. Or, hey, I'm about to wake up, do something, wouldn't you please? And the way I want you to think about it is what happens when you touch a hot stove. You don't say, oh, it hurts. It's, right? You withdraw, and then it's ouch. So if you don't have an EMG spike, you don't have arousal. If you don't have arousal, you don't have nociception, pain, or whatever you want to call it. Here we go. I'm going to show you this thing blown up real tall. So your goal is where the arrow is. If skin incision, trocar puncture, or multiple local anesthetic happens and there's no response, this is a spontaneously breathing patient, and there's no EMG response, you have prima facie evidence of NMDA receptor saturation in the beginning of opioid-free anesthesia. Now, the great advantage that I had in my practice at the surgeon was injecting lidocaine and epinephrine. But as we'll talk about later, he sees epinephrine effect and he thinks, oh, great, everything's perfect. And when the patient moves under sedation, deeper anesthesia, deeper, deeper. Doesn't work that way. So this allows you to tell the difference when the patient moves under sedation. If they're in that 60 to 75 range and there's no EMG activity, the patient is asleep and amnestic. Okay? And all they need 98 to 99% of the time is a little more local right where he's dissecting. Okay? One wag of a surgeon said to me, he says, well, if I have to inject a local anesthetic, what do I need an anesthesiologist for? Finally, after thinking about it, I said, maybe to tell you when you need to inject a little more. Did I go backwards? I'm sorry. I think I went backwards. I'm still going backwards. I hate it when that happens. There we go. So this is the objective evidence, assuming you have the freestanding monitor. Okay, not everybody has a freestanding monitor. I recognize that. But since I was working in offices that didn't have anesthesia machines, and we were talking about the dark ages 25 years ago, before office anesthesia was regulated and people said, okay, we'll bite the bullet and have an anesthesia machine even though we just do IV sedation. So this is the story. If the patient moves and there's no EMG spike, he just needs more local anesthesia. All right. Vasoconstriction only gives you evidence of adequate epinephrine effect. And the differentiation for you is the presence or absence of EMG, either increase in number in your plug-in monitor or the trend. A lot of people want to ask me about nifty 50. Why do I just give 50 milligrams of ketamine? Well, the goal is to produce immobility in response to local anesthesia injection. For my practice, for other people's practices, it's immobility with skin incision or trocar punctures. And that's called a dissociative effect because you're dissociating the cortex from the rest of the body. It's the ultimate regional anesthetic, but only lasts for about 10 to 20 minutes. So if you give that 50 milligrams and they're doing God knows what before they do an incision 20 minutes later, you've lost the ability to protect the brain from recognizing the surgeon's bodily invasion. So as far as the body weight issue goes, I have used the same 50 milligram ketamine dose for patients weighing as little as 30 pounds and as much as this young lady here at 30 kilogram to 145 kilograms in patients as young as 7 years of age and as old as 94. So my conclusion is that ketamine is a very unique compound in our armamentarium, and the number of NMDA receptors doesn't vary with age or body weight. Now, I know that's heresy, and when you tell your anesthesiologist sort of just, that's okay. It'll be very difficult to challenge his belief, but you can say, well, here's a guy who did this for 26 years. And you can't screw up in the office because there's no place to hide from your outcomes because the operating room in an office is admitting, surgery, and recovery. And by the way, there's no dedicated recovery room person. So you can't get away with whatever silliness you may have with a long list of a long list of orders. So again, we want to talk about dose and timing being critical to be successful with ketamine. If you give 50 milligrams of ketamine in the middle of the case, you've already allowed the brain to recognize bodily invasion. So it's not going to help you. And if you give it too soon before the stimulation, injection, or local anesthetic, you have the same issue. So to have opioid-free preemptive analgesia success, you have to give it 50 milligrams and 2 to 5 minutes ahead of time. Now, I didn't think this was a difficult concept, but when I presented to my colleagues in Montreal many years ago, I got a call 6 weeks later, and they said, Barry, it's a great concept, but it doesn't work as well if you give the ketamine first. So I kept thinking to myself, we had the talk, I gave you the papers, we had question and answers. What part of propofol ketamine made you think to give the ketamine first? I don't know. So it's a question of sometimes, I know what I've said, but I don't know what you've heard. So that's why I say ketofol, the mixing of the two drugs, it's a wonderful technique. It's not my technique. The problem with ketofol is that there's varying ratios of how much ketamine is in the propofol, and you can't measure either effect. So being somewhat OCD, I like to know what drug is giving me what effect and when I have to use more. The times that I was going to say 80% of 1,000 cases that I logged were done with 1 or 2 50 milligram doses of ketamine. So why a second dose, Dr. Friedberg? Many times in the early years, the guy doing a facelift, a right tendectomy, would only inject the first side because he was afraid the analgesia would wear off if he injected both sides. As years went by, I became more effective in convincing him to just go ahead and inject both sides because, surprise, surprise, the analgesia and vasoconstriction didn't wear off. So that's how we kept it to a minimum. The other thing I will tell you about ketamine that's very important is you never want to exceed 200 milligrams total dosage because patients aren't going to wake up very nicely. And you never want to give it in the last 20 minutes of a case. The last warning about ketamine, he said, there we go. There is a rare ketamine-associated laryngospasm, and unlike the laryngospasm you've heard with the classic crowing noise, the cords slam completely shut. There'd be no sound to warn you. Okay? The only warning you're going to get is a cough or a sneeze, at which time you give a milligram per pound IV lidocaine push. Because the traditional treatment, when it's subtotal closure of the jaw thrust and positive pressure ventilation, doesn't work. And that was my old chief at Stanford. That was his thing, Larson's technique, pushing the jaw forward and positive pressure. I said, great. If it's subtotal closure, it does work. But when they're completely closed, it doesn't want to work. And also, if you want to insist on jamming an endotracheal tube through these cords, you're probably going to produce some damage, which is definitely not good. Okay, emetic drugs abstain, the third leg of Friedberg's triad. Here are the usual suspects. All the drugs that everybody knows you have to use because, after all, the unspoken syllogism is surgery is painful, opioids are painkillers, therefore all surgery requires the use of some opioids, the judicious use, right? Well, here's the reason you don't want to give these drugs. Christian Affel was one of those rare anesthesiologists to publish in the New England Journal of Medicine, which is a very high-end internal medicine journal. So it's almost unheard of for an anesthesiologist to publish. And he published the 4 factors that are most related to post-op nausea and vomiting. Non-smoking, female patients with history of nausea and vomiting or motion sickness, having emetogenic surgery, ENT surgery, abdominal surgery, cosmetic surgery. So when I saw this information, I reached out to Dr. Affel and I said, hey, you're talking about my patients. Those are my patients. And we're going to show you that 1990 paper that he was kind enough to cite. At any rate, what happens if you give opioids to these highly risk patients? It's like throwing the match in the gasoline. You're asking for trouble. Why do it? ORADIs is a very interesting acronym, opioid-related adverse effects, drug effects. We all know nausea and vomiting, respiratory depression, obstruction, aspiration, sedation, prolonged emergence. Definitely not good in the office setting. You want everybody home in an hour or less if possible. Cognitive dysfunction, brain fog, along with ileus, constipation, and urinary retention. Dr. Kessler looked at the consequences of having just one opioid-related adverse drug effect. All right? He found a 55% increased length of stay, 47% higher cost, a 36% increased 30-day readmission rate, and 3.4 times higher mortality risk. That ought to give you serious pause to think about, why do I want to keep giving opioids? Well, here's another kicker. Why are we so delinquent as a profession about patients' number one postoperative issue? Alex Macario in 1999 published 2 scientifically validated surveys surveying what did anesthesiologists choose from a list of what do they must want to avoid. Of course, we chose pain, right? That's what we're there to prevent. Patients chose emesis, gagging on the endotracheal tube, and nausea in preference to pain. People say, well, why should that be? Well, here's the simple fact. When you sign a surgical consent, you're giving some person permission to stick you with a knife or a trocar to fix what's wrong with you. And most people have been cut with something and they understand pain happens when you get cut. But it's not associated with being sick to your stomach. Okay? And rarely do people die from nausea and vomiting. They only wish they were dead. Okay. Back to Miller's Anesthesia, our Bible. Okay? Here is my 1999 paper. This is, like I said, it's a big deal to be cited by any later author. It really is. It means you're already ahead of half the papers that are published because none of the papers I published had anything to do with me getting tenure. Okay? Tenure was not something that I was really involved with at all. Okay? And so here he's comparing my 0.6% PONV rate in a high-risk group that he's defined with Paul White, one of the living legends of anesthesia, who's published on everything and everybody, right? And he's got 7%. And there it is in Miller's. I thought, God, surely the heavens will open and people will say, wow, that guy Friedberg really knows something. No, they're not interested in that. They're really not interested because PONV happens not on the operating table. It doesn't happen there. It's somebody else's problem. And yet we wonder, why do surgeons have such a low opinion of us? Because they rightly associated their patients who have emesis with the drugs that we've given during surgery. And so once you demonstrate to the surgeon that you care about what he cares about, all of a sudden you've built a tremendous bridge in a working relationship. Now I'm going to show you this clip that's going to inspire cognitive dissonance. In cognitive dissonance, I will tell you that anesthesiologists from different countries and around this country have come to watch me do anesthesia for abdominoplasty. And they, to a person, always ask the same question at the end. That was great, Dr. Friedberg. What was the trick? What did you give the patient we didn't see give? And that's cognitive dissonance. Okay. This clip is a 2009 clip. This was before end-tidal CO2 was a standard of care. I apologize for that. But the main reason I show it to you is to dispel the notion that abdominoplasty is a major invasive procedure. We're not sticking a retractor in and holding the rectus muscle apart. Okay. We're knitting together the membrane around the rectus muscle. That's an abdominoplasty. Does not require an epidural or spinal to do. All of the patients that I've done were done with subcutaneous tumescent anesthesia. I don't know how many of you are familiar with tumescent anesthesia, Klein's solution, it's called. Plastic surgeons call it wetting solution. It's ultra diluted, 0.05%, not half percent, 0.05%. So here we go. This is a quick clip. You see the blue edges of the rectus sheath.
This afternoon.
And all we're doing is knitting them together. However, once I pulled an endotracheal tube in my doing a hospital-based patient, coughed and popped those stitches. The surgeon wasn't liking me very much.
You like that camera?
I love it. I'd like to stop that right there if I could. No, I guess I can't. Okay.
Flip.
And what you see on the biz, you see a number of times that the EMG spikes up.
This afternoon.
And it goes back down, and the biz stays within the range that I've selected. Now, I expanded the range from 55 to 80 because I hate to see alarms. But basically, I'm looking to keep them 60 to 75. And 4,000 cases, not a single patient, none of them received midazolam. Not a single patient under recall.
I love it.
Or awareness.
Is it HD?
See the spikes?
Yes.
See how responding to those spikes with enough propofol keeps it in range. Okay, so that's a room air spontaneous ventilation. There's an O sign. And I show you this not to demonstrate brilliant airway management, but to show you that the minimal amount of invasion is required to bring this sat back up. So listen carefully. Here it comes. Pretty shocking, don't you think? There's the abdomen, it's dissected. You see the spikes? Responding to spikes keeps the biz within the zone. It's pretty simple. It's kind of a neat virtual video game if you can get your hands on a freestanding one. And if you can, again, if all you have is the plug-in module, you can focus your attention on that EMG number in the absence of muscle relaxants. And here is the same patient less than 5 minutes after we've turned the propofol off. Was it pretty good?
Yes.
Did you remember anything? You've been asleep for 4 hours.
No.
Don't remember a thing. No bad dreams.
No.
Wonderful. So that was really a good experience then, huh?
Yeah.
You like Dr. Lin, don't you?
Yes.
He's the best. And
Yes.
Anais held your hand, and I held your other hand, and you had a good snooze.
Cool.
And no dreams. Don't all your patients
No.
sound like that?
Fantastic. All right, well, speedy recovery.
Right? It's like cheating. It's so simple. It's so beautiful, and it's so not stressful. Now, I will tell you, since days have gone by and we have to measure end-tidal CO2, it is more responsive than the pulse oximeter. And so what I do, instead of doing room air, I use a nasal cannula, the to nasal cannula. Through one, I trickle a liter per minute so people can say, oh, he really is still giving oxygen. It's homeopathic. It's really okay. And through the other, I measure end-tidal CO2. So I brought my practice up there. But I show you this because you say, God, that's unreal. I mean, how could that be real? And yet I've done maybe 800 of those cases. And people walk away, they can't believe what they've seen. So you've heard the expression, right? Seeing is believing. Well, seeing is also cognitive dissonance. They just, no, it can't be possible. So what is the simple paradigm to affect Friedberg's triad? I chose glycopyrrolate because it generates less tachycardia than atropine. If you can't get your hands on glycopyrrolate, by all means, use atropine. In the early days, again, I'll tell you a little bit about, I was curious to see, does everybody have to have glycopyrrolate? Again, with the idea of what's the least number of drugs I can give to make this case happen, to make sure that the patient is asleep and amnestic and has pain relief. And so not all of the 25 patients who didn't get glycopyrrolate required vigorous suctioning for the saliva, but the ones who did had such a sore throat that they might as well have had an endotracheal tube. So I said, I'm trying to avoid complaints in a cosmetic surgery practice. So I tell them ahead of time, you're going to have a dry mouth. Okay? I have a dry mouth right now. The other thing I tell them, which I didn't realize until I had a Biz sensor put on my forehead, is that hurts too. So I let the patient touch the sensor before I put it on their forehead. And I say, oh, you can't puncture skin with that, can you? No. I said, so we're not going to scar your forehead. It's going to be a little painful, but no big deal. Once again, patients know this, like the expectation of pain after surgery, the expectation of a little discomfort here. It's not a big deal. So full disclosure. So you saw my incremental propofol induction. Pretty simple. And the main thing is the great wisdom is staying out of trouble. You know, if your anesthesiologist is down the hall or not available and whatever, you know that you never have to worry about, can I get help? In the office, there's no video laryngoscopy team to come in and intubate somebody that I've precipitated a disaster in. There's no cold blue team. All I've got is 911. That's not a very satisfactory backup, but at any rate, that's it. So you're going to titrate and maintain the Biz between 60 and 75 and having a baseline EMG. Now, again, the plug-in has values of somewhere between 26 and 30 as a baseline. So you know when that baseline starts to move up, it's not as pretty as the little picture that I showed you, but at least you know, what does that mean? You know, one of the great things before we had this device was trying to figure out, read the tea leaves. What do these changes in heart rate, blood pressure mean? Is it fluid shifts? Is it blood loss? Do I need to fill the patient up? Or is it pain? What should I do? Well, this kind of makes it really, really simple. This is what to do. I'm about to wake up. Please give me some more propofol. Thank you very much. And then 2 to 5 minutes before they inject with local anesthesia, before they make a skin incision, a bolus of the nifty 50 milligrams of ketamine. I will tell you from the beginning, I started with 75 milligrams because I learned about Valium and ketamine, diazepam and ketamine from Charles Vinnick, Las Vegas plastic surgeon. And in the first 25 cases, I had 2 or 3 patients wake up with horizontal nystagmus, which I said, well, maybe it's too much ketamine. So I cut it down to 50. These numbers are simple because the commonest, well, there's 3 concentrations of ketamine, 5 milligram per cc, 50 milligram per cc, 100 milligram. So like multiple guests, the middle choice is the right choice, 50 milligram per cc. You don't have to fool around with tricky calculations. It's easy. And then I said, well, geez, maybe if 50 is still good, maybe I should try 25. So I did. And 4 to 5 times the patient was immobile. And the 5th time I had to stop the surgeon from injecting, give the second 25, and then the patient would lie still. So the idea is that once the patient is adequately asleep with a stable level of propofol in their brain, there is no downside to the 50 milligrams. All right. The other thing I want to share with you with Dr. Parsons' experience at the Main Street Surgical Center in Orange, California. He built a 5-room surgery center with his orthopedic surgeons, and he did 1 room, and a select group of anesthesiologists from St. Joseph's next door would come over and rotate through. And after years of talking to him, I convinced him to use the Biz monitor, as I showed him with the EMG and what to do with the spikes, and give the 50 milligrams of ketamine 2 to 3 minutes before skin incision. Unbeknownst to me, he was still giving 2 milligrams of midazolam and 2 cc's of fentanyl. I only found out that later. But the story goes like this. As time went on, the fellows from St. Joseph's kept asking him, why do your patients look so much different than my patients? 50 milligrams of ketamine, 2 to 3 minutes before. Gradually, over time, they all got it. And all patients are benefiting tremendously. This is not something you need a level 1 study to see the difference. When patients wake up, you saw how Lily looked, right? She didn't look traumatized, did she? Because her brain never knew her body had been invaded. And to follow that up, she had adequate local anesthesia. That's it. That's a minimally invasive anesthetic. So the second to last thing is you're going to my surgeons inject lidocaine with epinephrine tumescent solution. We'll talk a little bit about that. And then before closure, we splash some bupivacaine, in the field. And it doesn't need to be injected because it binds very quickly to the tissue. Okay? A little bit about tumescent lidocaine. Klein published this back in 1990. He started doing it in the mid-80s when he couldn't get the local anesthesiologist to come give general anesthesia. He's a very smart guy. He's a PhD as well as a dermatologist and internist. And so what he did was take 500 milligrams of lidocaine and put it in 1,000 cc's of normal saline or lactated ringers and 1 milligram of epinephrine. So the resultant concentration is 0.05 lidocaine and 1 to 1 million epinephrine. You're thinking, how in the world could such a dilute solution provide anesthesia? Well, I can assure you that for eyelids and noses, it doesn't. You have to use a more concentrated solution, but you're only using very small volumes. Okay. So when I was trained, it was 7 milligrams per kilogram lidocaine with epinephrine. And when you see these numbers, 35 to 55 milligrams per kilogram, it's an OMG moment. You're thinking, how can this possibly be? Well, it's very dilute. It's in a vessel poor group, which I've never quite figured out how Ted Eager did that, because I had the great misfortune to work with a plastic surgeon in the mid-80s who did dry liposuction under general anesthesia, and it ain't vessel poor. It bleeds like crazy. They typically got at least a unit, if not 2 units of autologous blood to replace it. So you're providing vasoconstriction, and it takes 24 hours to completely resorb this dilute solution. So you're sucking half of it out, and it's the other 24 hours for the rest of it. Without liposuction, Klein says 28 milligrams per kilogram. All right. Since we're in Florida, I had to throw this out there because I'm sure you've heard about people dying from liposuction in this state. General surgeons are very fond of general anesthesia. Maybe that's where the general comes from, I'm not sure. And dermatologic surgeons, of which Klein is one, favor tumescent anesthesia. And it turned out in a 4-year study in the Florida thing that the plastic surgeons exceeded deaths from that of dermatologic surgeons. Had to throw it in, I'm sorry. People say, well, tell me about your outcomes, Dr. Friedberg. If this is so wonderful, what's going on? Well, for the 20 years that I had biz EMG, and I'm doing opioid free anesthesia for more than 4,000 patients, by the way, for more than 100 surgeons, not just 1 or 2 surgeons. There was not a single pain or PONV hospital admission. All patients had commercial insurance, so that was not a barrier if they needed to go to the hospital because they were too sick to their stomach to go home or they had unbelievable pain. No, they just didn't need to. And those are the 2 commonest reasons for unexpected admission from day surgery. They are all discharged to home in around an hour, okay? And none of them required professional aftercare givers. It's unbelievable when you see these abdominoplasty patients walking out like this. How can this be? Well, you didn't hurt them. They didn't hear anything, feel anything, or remember anything. How many more drugs do you want to give? So, as I was telling one colleague, when I was trying to extol the virtues of minimally invasive anesthesia, he said, Barry, that's great, but the more drugs I give, the better I feel. Okay, well, how about the patient? How about, what's going on here? All right. So people say, well, gee, what about adjuvants, Dr. Friedberg? Tell us a little bit about adjuvants. Well, in the dark old days, when I'm trying my best to spare the cost of proprietary propofol Diprivan, it's $12 to $15 for a 20 cc ampule, and I'm averaging 3 ampules an hour. So figure out for a 4-hour facelift, we're talking about, $100 worth of drug. Of course, the patients are paying anywhere from $5,000 to $20,000, but that $100, the plastic surgeons really focus on. So I'm giving clonidine, which is a alpha-2 agonist, and we'll talk a little bit about the stronger one, dexmedetomidine. And I thought this was great. I published a study where I showed a statistically significant 30% decrease in propofol. Gee, what a clever guy. Then propofol becomes generic, and all of a sudden there's not as great a press to save propofol. So I stopped giving the clonidine. There were no difference in the outcomes. So the reality is measuring is still better than guessing. If you're titrating to 100% of patients, I did forget to tell you one thing, probably many things, but 25 to 50 micrograms per kilogram per minute is a pretty average dose range for my patients. The first really sensitive patient was a Jewish anesthesiologist from Eastern Europe. And when I told her propofol, she said, propofol, oy vey. The last time they gave me propofol, I slept for 2 days. 2 days? Who sleeps 2 days from propofol? So along the line with, what do you do with your pump when the biz keeps going down? So I dialed back from 25 to 20 to 15 to 10. Nothing. 7.5, 5 mics per kilo. I chickened out at 2.5. 2 would have been perfect. At 2.5 mics per kilo for a 4.5-hour case, I'm thinking any minute she's going to sit up and say, no, when are you going to give me some drugs? Right? Nothing. I turned off the propofol at the end of the case. It was like throwing a light switch. She sat up and said, that was the best anesthetic I ever had. I never heard, felt, or remembered a thing. Talk about cognitive dissonance. Who's going to believe there's an otherwise healthy human being walking around out there who only took 2.5 micrograms per kilogram per minute of propofol to stay asleep for 4.5 hours? And then I had at least 2 more patients. But this time I went all the way to 2, which is, a tenth of my low average. It's insane. But again, measuring is better than guessing. So another clever time when Vioxx was on the market, I said, aha, this is going to be great. We're going to throw this on board and it's going to be super. And I thought, great, we're doing better for these patients. Okay? Then Vioxx comes off the market. I can't give it anymore. And guess what happened to outcomes? Nothing changed. Okay. So then I tried Tylenol, acetaminophen. But the plastic surgeons weren't going to sit still for the cost of IV Tylenol. So we gave PO Tylenol. We tried it for a while. Didn't seem to make any difference. Magnesium sulfate, the same story. 2 grams IV early in the case. Didn't make any difference. Now, I will tell you that up until the time I had my own total hip replaced in 2008, I wasn't using any dexamethasone. And because I was so insistent that the surgeon allow the anesthesiologist to give this, despite his concerns of delayed healing, which never happened, I thought, okay, that's one of the things I've done since 2008. And Toradol, ketorolac, again, 30 to 45 minutes before the anticipated end of the case, I would get on board. That seems to help. I have no experience with IV lidocaine, which my friends in Europe and other people doing opioid free are using. So when I say Friedberg's triad is a pathway to opioid free anesthesia, it's not the pathway. There are other pathways you can go, but I like to reduce things to as simple as possible, the fewest moving parts, the fewest possibility of side effects and difficulties. I'm big on boredom, and I hope that is a strong message for you guys. Boredom is good. Okay. The same story with Precedex or dexmedetomidine. It was very expensive when it first came out. It was tricky to administer and often had low blood pressure, things that I just really didn't need, so I never bothered with. And liposomal bupivacaine Exparel, I can tell you that my wife had an interscaling block for her shoulder replacement with 50-50 bupivacaine and liposomal, and it took her 3 days before she could move her hand. So it's a pretty nice addition, but I never used it in my thing. So I want to leave you once again with what I hope posterity will remember me for. Friedberg's triad, measure the brain, preempt the pain, emetic drugs abstain. Simple. It's not a haiku, but it's close. It's close. Now here's a bombshell study I wanted to share with you. This came out a couple years ago. I believe they were out of Switzerland. And they did 23 studies. They did a meta-analysis comparing 23 studies of opioid-inclusive anesthesia compared to opioid-free anesthesia. Surprise, surprise. Giving opioids during surgery doesn't stop post-op pain. Why would it? You haven't blocked the NMDA receptors, right? But it increases post-op nausea and vomiting, the patient's number one issue. So that's good. All right. This gentleman and I were on an office-based surgery panel at least 25 years ago, and he never forgot it, apparently. He's on his way to becoming ASA president, Mike Champeau. He's up in Palo Alto. And he sends me this email. He says, you were just 25 years ahead of your colleagues. You know what that'll do for you, right? Get a lot of warm, fuzzy feelings. No, not really. They keep looking at you saying, go away, Dr. Friedberg, go away. Why don't you just shut up and go away? He says, well, if you want better outcomes, here's a simple way to do it. Never claimed it's the only way. This is a simple way that's worked for me 25 years, including the non-processed EEG. And so there you have it. When I looked down at here, originally it said 57. I thought, how could I have been speaking for 57 minutes? But it's 57 minutes to go. It finally got to that part. And so I say, thank you all for coming. Thank you all for listening. And I hope you'll have some questions. And I'd really be excited if you could ask me a question I haven't heard. But no question. The only dumb question is the one you didn't ask. Thank you.
Does anyone have any questions?
Do you have any information about, well, first of all, I want to know what your intraoperative bolus is when you see that EMG spike. Is it that 50 mics per kilo? You just trigger a bolus?
Typically I go 100 mics once or twice. And if that doesn't have any effect, I'll go up to 200 mics. The whole idea is that you don't want to give so much propofol so quickly that you wipe out spontaneous ventilation. Okay, so you do have that 15 to 30 second interval to respond. And if you respond with alacrity, one of my favorite 50-cent words, with alacrity, that's an excellent question. And that's how I would do it. And if the biz didn't stay in the range after the boluses, well, I would increase the basal rate too. So these are things that, an old cardiac anesthesiologist does. It's a lot like trying to get a dopamine level. You don't give a slug of dopamine up front, right? You start low and you titrate up to where you want to go. And so I think most of us would agree 50 mics per kilo of propofol is a pretty low dose. And I got there when I started doing dental sedation, because you really don't want to be bagging somebody in a dental chair because you've knocked out their respiration. Yes.
What kind of stories have you heard about this method being used in, for instance, endo, EP, IR, outside the OR?
A lot of ER docs like ketofol because it's quick and simple. They don't have to titrate one way or the other. They just give a breathing. But I think anytime you're doing sedation anywhere, that incrementally sedating patients, and for the first 5 years I didn't have a processed EEG monitor, I would titrate to loss of lid reflex and loss of verbal response. Mrs. Jones, are you awake? Are you awake? She's not talking back and she doesn't have a lid reflex. It's okay to give the ketamine. She's not going to hallucinate. Thank you for the question, though. Excellent question.
Hi, good morning. I've got a couple of questions I want to ask. You mentioned earlier in your presentation about roughly about 360 I call it fatalities from patients being over-anesthetized. With a patient, when you consider to be over-anesthetized, what sort of levels of BIS would you be looking at to sort of quantify that? And also, what is the perceived sort of increased mortality of someone that runs sort of a low BIS perioperatively?
Good questions. Low BIS is anything below 40. That's basically what I would define as over-medicated. It's very hard to quantify those deaths because there's lots of other factors in there. Most commonly, people giving opioids along with it and compounding the respiratory effects. So when you saw the abdominoplasty clip, you have to realize that I'm titrating to the brain monitor with the brain stem, with the pulse oximeter, and titrating to cortical effect with the bispectral index or processed EEG. So even though I didn't have an end-tidal CO2 over all those years of hundreds and hundreds of abdominoplasties, still worked out pretty well. Did that answer the question?
Yeah, I've just got one more question.
Great.
So following on from that, would you recommend using other types of monitoring within BIS, sort of like suppression ratios and sort of EEG density spectral array as well?
If it works for you, I would say great. This is what worked for me. It solved a problem that I had for a whole year of frustration. I can't tell you what it was like because, I mean, who knew much about anything of processed EEG monitoring in 1998? So I'm frustrated and I'm talking to the salesman. I say, how come 1 minute it's this thing? And it's, well, it's a processed value and it takes, 15 to 30 seconds. And I just can't seem to get that into my head because I'm looking at a trend that goes from left to right. And we're used to seeing EKG trends that go from left to right and pulse oximeter trends and other things. And I'm seeing this trend and I can't put that information together. And it wasn't until out of frustration, I think, he said, why not trend EMG? I know there are people who use suppression ratios. I never needed it. It never seemed to be something that I was curious about. At least I was happy I could make my little toy work and work to the patient's benefit. Okay?
Yeah, that's brilliant. Thank you.
You're welcome. My pleasure. Up front.
Anyone else?
Up front. That's an excellent question. The question is, how do I decide when to redose the ketamine? Now, remember, again, this is cosmetic surgery, right? And I've convinced the surgeon that if he re-injects some local, when we have the biz the way it is, and he's done that 2 more times. So in other words, he's injected initially, and after 2 more times, we haven't eliminated patient movement. That's my indication for additional ketamine. And with the caveat that you never want to go above a total of 200 milligrams and never want to give ketamine in the last 20 minutes. I apologize, that's not one of the slides. It's one of the things that kept me up last night trying to think of what are the things I forgot to put in there that'd be really, really important to help people stay out of trouble. Because again, to me, the greatest wisdom is staying out of trouble, not getting out of trouble. It's important to know how to get out of trouble. I don't minimize that in the least. But life is so much simpler when you don't get into trouble. It's easier on your coronaries, and it's easier on the patient's coronaries. Yes? I kind of like 50. 50 seems to be a nice saturating dose. And again, if the patients are in the zone, there's no downside. But there is some downside if you're not saturating those NMDA receptors. And again, if you give the 50 milligrams in the case and never having given it the front, that's like closing the barn door after horses have left. You've already allowed the patient's brain to recognize bodily invasion, whatever you want to call it. Nociception, pain, bad juju, right? Okay? Yes, sir. It hasn't, the question was about interference from the cautery, hasn't really been a big issue. And when it is, it goes away quickly. Every once in a while somebody says, well, I still see a little transitory increase in the biz with the ketamine. I said, yeah, it's transitory. It's not a big deal. It's okay. Did you have a question? No? No? Okay. Yes? How frequently do I experience patients having hypertension? More often than not, I'll see tachycardia from epinephrine. And that's when I get my labetalol out. And I give 10 milligrams, not 5 milligrams and 5, because we were trained to give 5 and 5 because we had opioids on board, which tends to produce bradycardia. But without the opioids, you don't have that issue. So I would just hit them with 10 milligrams of labetalol. Hypertension, rarely a problem. But at that point, if the labetalol doesn't also deal with any blood pressure increases, I'll go to a little apresilene, 10 milligrams. But, not very common. But you can imagine people standing in the operating room watching an abdominoplasty, which they come in believing this is a major invasive procedure. I'll agree that it's a large superficial dissection, but it is not invasive because it is extraperitoneal. Just like breast augmentation is not intrathoracic, okay? And a facelift isn't intracranial. These are all minimally invasive surgeries. They may be expensive dissection, but minimally invasive. Okay, so we had something here, I thought. Post-lecture questions. Are we supposed to do that now? No? Okay, forget it. Any other questions? So it really is a lot more fun to take care of patients, no matter what challenge you think they are, because you're approaching them slowly. How many of you have had take calculus? Ever take calculus? Okay. You remember when you're trying to figure the area under the curve, and you keep cutting smaller and smaller pieces until it's no longer a curve, but it's a rectangle, right? And then you add up the rectangles. That's kind of what I do with the propofol induction. It's real simple. It's really hard. I have never gotten into trouble with this. And, 26 years and never had to intubate. The only time I routinely use an LMA is for rhinoplasty. And I use an armored tube so I can tape it down to the chin so the surgeon can see where he's operating. Other than that, like I said, 2/3 are either the facelift position or facelift with IV bag, unheated, or a soft nasal airway. Usually the one with the ring on it that slides so you can adjust the length. But I've had an awful lot of fun, and it's really been a pleasure to be here with you. And I wish you all the very best with your careers. You have my email. You can reach out and ask me any questions you didn't want to ask today, or just send me a nasty email saying, I tried it, it didn't work. Okay, well, let's examine what you did, and maybe I can help you make it work. But yeah, the story of Dr. Parson and the orthopedic surgery thing, here's a guy who's giving 2 milligrams of midazolam, totally superfluous, 2 cc's of fentanyl, again superfluous. He's inducing with propofol. I don't know if he's bolusing or not, but he's probably carrying him on sevoflurane and oxygen and giving the 50 milligrams, the nifty 50, beforehand. And 4 anesthesiologists who didn't want anything to do with ketamine. I mean, you have to remember what ketamine was 25 years ago. That's why I coined that expression, non-opioid preemptive analgesia, to avoid using the K word. Because if you use the K word in front of a group of colleagues, they immediately thought you were insane. Because nobody uses that drug, Dr. Friedberg. Now, at least, they even write about it in Allure magazine, right? So, okay.
Thank you very much.
Thank you all. Thank you very much.